For every disease process, you've faithfully memorized the list of risk factors. And you have this sort of intuitive sense that, smokers get lung disease, smokers get cancer. We get how that works. But remember what our overarching theme is. Clinical medicine is built on a foundation of basic medical sciences. So we know these risk factors work, right? Lack of activity leads to atherosclerosis, smoking, lung cancer. We can do that. But there is basic sciences underlying that. And so if the purpose of the exam is not the what, but the why, then ask yourself, why are these risk factors so powerful in the diagnostic process? And it comes down to a single mathematical biostats word, prevalence. Prevalence is this idea that is so deep in the diagnostic process, it has to become a way of thinking. If you're new here, I'm Dr. Philip Tisdall. I practiced for 40 years. I've been teaching well over a decade, and I wrote a book. And we're developing a community of people who are going to learn how to do medical school so that exams are not only unstressful, they're going to carry through and make you a great clinical clerk. So hit subscribe. We've talked in previous videos of how all diagnostic medicine is a chief complaint from which we can form a differential diagnosis. And we've talked about this idea that a differential diagnosis is not the shotgun blast of a bunch of possible diagnoses and you hope for divine inspiration that one will light up like day glow. It doesn't work like that. You start with a differential that says, which organ system could I be in? Shortness of breath is heart, lung. Now, stop for a sec. I'm not saying every possible diagnosis. That's just hopeless. Who can learn 400 things? It's always 80-20. 80% of all diseases come from a handful of diagnoses. Those are the ones we carry in our head. So in your mind when you're learning, you're saying, what am I going to keep in my head? What is the long list? You go look that up. So when I say chief complaint and you say differential, you start with which organ systems? Shortness of breath is heart and lung. From that, we develop this idea of which family of diseases are we in. But disease is a floppy term that we use lots of different ways. What we mean here is a specific tight view of pathophysiology. So when I say shortness of breath, heart, it's a very specific pathophysiology. It is the pathophysiology of left ventricular congestive heart failure. And I'm clearly saying that with some meaning, and I can say it with some confidence because I've got a really tight picture in my head when I say that. So now we come to this idea of pathophysiology is a really tight way of looking at the disease with a really tight image and a really good story to tell through it. And if that works well, if it's a disease that lends itself to a good pathophysiology, you can do symptoms, you can do the physical exam, and all of your testing inevitably have to come out of that picture. So now you're not learning a bunch of lists. Now you've got a single picture with a story. And when someone asks you about that, you flip that up into your head and you say, where am I in this picture? That's what we mean by pathophysiology. One of the surprising elements of this is not only what you do find, positive findings of symptoms and signs and tests, it also tells you what you don't expect to find. No better example here, one of my favorite questions, is acute cholecystitis. Because when you say, tell me the pathophys of acute cholecystitis, you know what I'm going to say? Oh, 2 phases, not 1 phase, 2 phases. First phase is obstruction with cramping. Second phase is going to be breakdown and inflammation. So when we say first phase just obstruction, guess what? There's no inflammation. There's no physical findings. So yes, we've got this colicky epigastric pain, but your physical exam is negative. That's important. If it's positive, it's not first phase of acute cholecystitis. That doesn't have inflammation yet. Yes, second phase, when everything starts to break down and get inflammation, now we see the pain move. So now it goes from epigastric in the center. Yeah, now it's going to right upper quadrant. I've got an inflamed peritoneum. Oh yeah, everyone can tell you Murphy's sign now. Well, now all of a sudden we've gone from should not have physical findings to should have physical findings from a single, simple picture of pathophysiology. So once you have a good picture of pathophysiology, now all of a sudden you can say, what would I expect to find for symptoms, signs, and testing? No better example than if we go, for example, to chest pain. Now, if you ask me what my picture is, no kidding, I'm going to use a transverse CAT scan C5 of the thorax. I really am. If you've got that picture in your head, and yes, it's a standard picture to draw, you're going to have, from the outside in, chest wall, pleura, pericardium, aorta, and then what we're really looking for is angina, ischemia of the heart. Okay, so once I say inflamed chest wall, inflamed pleura, inflamed pericardium, then you go, what are you going to find? Well, you're going to find something with the pain. Chest wall, it hurts when you push. Pleura and pericardium give you rubs. Great. What are you going to find from the aorta? And the answer is, well, you can't see it and you can't hear it. So I guess you got to image it. Okay, well, once you have that picture, that's pretty obvious. Tell me about the angina. Well, here's what's important. It's negative physical exam. It's not chest wall pain. It's not a rub. Can you see it or feel it? Well, no, you can't see or feel the heart. So I guess we've got to have testing. Well, is it going to be lab or imaging? The answer is, well, not imaging. It's got to be lab. So I need two. I need the EKG for ST depression ischemia, and I need evidence plus or minus of necrosis. So I guess I'm going to need troponins. So look how fast the story unravels. I've got chest pain. I expect you to tell me the physical exam. I need negatives in the physical exam. It's not chest wall or rubs. I'm going to have to, in certain circumstances, have imaging to look for the aneurysm of my aorta. But if it's heart, I got to have an EKG and troponins. Any question's got to give you that because it's got to be part of the diagnostic processes, all from a nice, tight mental image of the differential diagnosis of chest pain. So when we say chief complaint gives you a differential diagnosis, for each possibility in that differential diagnosis, you've got to have a really good pathophys, because that tells you what you can expect from the history and the physical, and if testing is going to be needed, and it includes the negative findings. So if I say to you edema, what are your organ systems? Look what we're going to come up with. We're going to come up with liver cirrhosis. We're going to come up with heart, right ventricular congestive heart failure. We're going to come up with kidney, chronic kidney disease stage 4. And we're going to come up with kidney nephrotic syndrome. Do you think when I say those words, I have a little picture in my mind to run a story through? I'm just waiting at that point for you to tell me which are going to come from history, which are going to come from physical. But if it's nephrotic system, I guess I got a dip for the protein, don't I? All from a differential of 4, each with its own pathophys. Okay, so we've developed this idea of pathophysiology. If I've got late cholecystitis, I have to have a positive physical exam when the fundus of the peritoneum rubs under my fingertip. It's got to be there. Do I have to have a stone? Sure, 95% are obstructing. So you tell me I got a gallbladder with a stone and a positive Murphy's sign, I'm done. I've got acute cholecystitis. That's really different than saying I've got a female with multiple children who's overweight and she's 44 years old, right? Because if you take a look at all 44-year-old multiparous women in the United States, 15% of them have gallstones. Yeah, that hasn't given them acute cholecystitis yet, has it? It just tells you they might have it. So look at the difference now. I've got a stone impacted in the cystic duct. I've got obstruction. That's pathophysiologic. So let's look at the difference between pathophysiology and risk factors. If I have a gallstone, that's only a risk for obstruction. If that gallstone is impacted in the cystic duct, I do have obstruction. So a stone impacting is pathophysiology. A stone in the gallbladder is only a risk factor. Quite a big difference. So when we're telling our story and we say, what is the likelihood of gallbladder disease? You say, well, the likelihood goes up if they are over 40, if they are female, if they've had multiple children, right? And if they are overweight, the cheeky 4Fs. But none of those make your patient have acute cholecystitis. That epigastric pain could be heart, right? But the second I tell you I have an ultrasound with an impacted stone and edema of the gallbladder wall, now I'm into pathophysiology, not risk factors. One is going to be diagnostic. The other only changes the likelihood of where you're going to go next to prove what you suspect. So a risk factor is not truly pathophysiologic. It only increases the likelihood. And there's a mathematical basis for that. It's this infinitely important idea. Predictive value positive is proportional to prevalence times sensitivity. That's the biostats underlying why we talk about risk factors. So let's talk about each of those. It's so important. We could talk about this every day and it would never get old. Predictive value positive says, what is the likelihood that this finding represents disease? And the likelihood depends on prevalence and the sensitivity of the test. Yeah, I can't remember the true definition. I don't even try to remember the true definition. When you say, what is prevalence, honest to God, 40 years later, this is what I put in my head. If you have 100 normal people, how many have the disease? I actually do say 100. I mean, obviously, a large number to be better. I can handle that. It served me well. It'll always work. Prevalence equals, from this population of 100, how many have disease? So if I pulled 100 people off the sidewalk and said, how many will I find gallstones in? The answer is, if they're middle-aged, 7% of males and 15% of females. Sensitivity says, if I use this test, how many people with the disease will test positive? So, for example, in lupus, ANA is 99% positive. It's really sensitive. If you don't know, write in 95%. Most of the tests that we want to use in routine medicine are that good. So you sort of start, how do I think of sensitivity? Start at 95%. 95% of the people with disease will test positive. Let's use my favorite example. Let's go to prostatic specific antigen, PSA. Why not? Let's take two different people. I'm going to start with an 80-year-old with a palpable nodule on his digital rectal exam and back pain. He has a PSA of 400, normal less than 5 nanograms per milliliter. Now I'm going to have a 22-year-old who has had unprotected sex with multiple females, comes in with a fever, says, I feel like I'm sitting on a walnut, and he has a soft, tender, boggy prostate. He has a PSA of 400 too. Exact same test, isn't it? Exact same number. Let's just see what prevalence does. Well, over 80, right? Degenerative malignant. Somewhere in the order of 70 or 80% of males of that age will have adenocarcinoma. He's got a palpable nodule. Sure, cancers are mass forming. Give me another cause of a mass in the prostate. And he's got back pain. Back pain is the first and commonest metastasis of prostate, and other than screening, the commonest way it presents. Yeah, what do you think? Old guy with a palpable nodule and back pain. What do you think his PSA is from? It's diagnostic of cancer. Yes, we'll still biopsy to prove it, belts and suspenders. But I promise you, if that biopsy is negative, you just missed the cancer. Let's go over to our 22-year-old who's in the absolute peak period for venereal disease. Do you think gonococcal prostatitis causes acute inflammation and destructive tissue changes in the prostate? Oh, I'll bet. So do you think that leaks into the blood and his PSA goes up? Of course it does. If you came to me and said, I'm going to do a biopsy, I'd say, overruled, you're not, because the prevalence of his age and his lifestyle says that is an acute venereal prostatitis. Notice, same PSA, all I've changed is prevalence. Prevalence drives diagnosis. Okay, so we've established prevalence drives everything. You should think of prevalence in a couple of different ways. There's prevalences that are so common, so overridingly important, you built them into every case, whether they're going to help you or not, because it's just how we see it. And that's your age, gender, time frame. So when you talk about age as a prevalence, over 65, degenerative or malignant. Can they fall off a curb and break their leg? Of course they can. But we're talking about how you think about it when you approach a chief complaint. When we talk about middle-aged women, we talk about endocrine and autoimmune. And when you're talking about someone 25 and under, you're talking about hereditary congenital. Does it have to be? Nope, but we've sure moved the prevalences. Gender, very straightforward, right? Gender is kind of pathophys, isn't it? Male gets male reproductive, female gets female reproductive. But atherosclerosis is so prevalent in our society, and females get that 20-year hiatus from their estrogen projection. So we always include male in anything that could be related to that, because males are +1 prevalence for athero, females are -1 prevalence for athero. So age, gender, obviously pretty important. Time frame. Okay, you can argue time frame is pathophysiologic. I get it. That's perfectly fair. Acute and chronic defines pathophysiologic processes. It's just so overwhelming important, and it just kind of trips off the tongue when you say age, gender, time frame. I include it with prevalence. You want to argue it's pathophys, that's perfectly okay. But you always start every discussion with age, gender, time frame. The other prevalence I kind of always include is where is the care given? That's not a hard prevalence changer, but it certainly gives you a feeling for how serious and urgent is this. If a patient's been brought in an ambulance to an ER, very different than if they've made an appointment and they're seeing the physician in her office. So I always include where we do the care. It's a good colorizer. Different than when we talk about disease specific. So if you're talking about something like chest pain, and we're talking about angina, we know what the obvious risk factors for atherosclerosis are, because that's going to be cardiovascular disease. They're going to be diabetes, hypertension, hyperlipidemia, and then some other rare things like sedentary lifestyle. So you're always going to include those as risk factors if you're talking about chest pain. But there's also some important negatives. And remember we said how chest wall can give you chest pain? Well, it's usually acute stress. So you would mention, have you done any new physical activity, like go shovel that spring snow out in the walk and you're a clerk, and that's way beyond your fitness level? Well, that would be an important positive or negative. So when we talk about constitutional or ever-present risk factors, age, gender, time frame, place of service. When we talk about disease specific, you got to have a differential diagnosis, and you got to do the risk factors for every one of those entities, positive or negative. So when we talk about prevalence, the ones you always give and the ones you kind of got to know the differential to give. If there's any single thing I can do to help you today that will change how you perform on tests and how medicine goes for you, always and for the rest of your life, it's understanding the difference between acute and chronic. Clearly, I just can't overstate it. So let's talk about it. First off, there's this nasty little fact. It has two different definitions, and you have to know the setting. There's clinical time frame, and there's pathologic time frame. Let's just get the pathology out of the way. Pathology defines acute as a process that has neutrophils, and it defines chronic as processes that have the repair functions of lymphocytes, macrophages, and going into fibroblasts. So there's a pathologic definition that correlates pretty well with clinical definition. Boy, clinical definition actually has to have definitions, and you've got to know it for each organ system. So when I say liver, when does that hepatitis B infection become chronic? The answer is 6 months. Well, okay, let's go to kidney. When does that glomerulonephritis become chronic? And the answer is 3 months. Well, every organ's different, isn't it? Okay, so now you've got someone with joint pain and inflammation. When are you allowed to mention the words rheumatoid arthritis? Yeah, a joint isn't chronic until 6 weeks. So this ability to go acute chronic matters. Heart, lung are what you'd expect, right? They're about 1 week. This is how tricky it can get. Let's do diarrhea. Acute diarrhea is less than 2 weeks. Chronic, more than 4. Well, apparently there's a little gap in there. You kind of have to use judgment. So when you start every disease process, in your mind, you're going to have two definitions, clinical and pathological. But when you're in clinical, remember, it varies with every organ. And if you don't know that, you're going to just be shouting out the wrong diseases in your head, right? When we talk about diabetic kidney disease, I promise you it's never acute. You don't even allowed to think of it for 5 years. And you don't start to think it's probable till 10. So understanding this time frame and the rhythm of diseases, if there's any single thing you get from this today, get your time frame right. Okay, so let's summarize where we are in this process. We've talked about the absolute centrality of chief complaint and differential. We've talked about how every differential has to have a nice tight pathophys with a storyline. And now I said, yeah, and then after you do all those, now we have to say, show me the prevalences for each of those entities in the differential diagnosis. They don't prove the diagnosis like a pathophys finding, but they set the stage for likelihood. And we've talked about how if you have a good set of prevalences for your differential entity, remember it includes negatives, because you've got this picture of pathophys in your head, don't you? Okay, so once you've done that and you've got your prevalences, then don't forget you're going to break them into the ones you always give, age, gender, time frame, and the ones that are actually differential specific, which are going to be your risk factors. And you sort of go, okay, well, I get it. How does medicine talk about them? And really, that's what they mean whenever they do epidemiology. And frankly, when I was writing the book, you'll see me flip-flop around, risk factors, epidemiology. Sometimes I put them with the history, but sometimes I put them with the pathophys. These aren't bright lines. You go, oh, it belongs here. Medicine is always about what's working in this setting. So get your prevalences right. They go in the second half of your history of present illness, and you'll use them in the exam. It's your examiner telling you what she thinks you want to be thinking about for the diagnosis. So they're very revealing by what you include and don't include. So epidemiology, risk factors, prevalence is one of the fundamental ideas of diagnosis. So it's this kind of thinking that is being asked of you when you get a good clinical exam. It's being, how do you think about? Do you recognize when I'm talking about atherosclerosis, you'd better be talking about diabetes, hypertension, lipids, and life activity? Because once you read those in the history, you know where the person's going. So learn this, and suddenly, all those exam questions, you can see the mind of their examiner. It's how every doctor thinks. So you can appreciate I come out of decades of practice and I'm over a decade of teaching, and I'm really trying to build an online community where students can come in and get this sort of, you feel like you want to study after you hear this lecture, don't you? Well, after you study, come on back and we'll talk about it, because you'll be surprised how talking about something really settles the ideas in your head. The other day I was talking to some students and we went to female reproductive hypothalamus. And we got into pulsatile signaling that eventually led us over to pulsatile PTH and over to how I think of the drugs of osteoporosis. Well, I promise you, that wasn't expected when you came to learn female physio. But boy, all of a sudden, you're suddenly pulling out osteoporosis out of the blue and giving it a good shake and a look-see. That's how you learn and make things sticky, is not just learning them and not just doing multiple choice questions. Come to a community that we're building that's going to include this ability to talk medicine. If you found this video helpful, come and watch this previous video and when I introduce deeply the subject of chief complaint and differential diagnosis. It's clearly a perfect companion for today's topic.